Welcome back to Menopause Taylor. I'm always so happy to see you, and I just love giving you this education. All you have to do in order to get the menopause education you deserve is watch all my videos in order, starting with the very first one. This is video number 347. Now I know that's a lot of videos, and there will be a lot more. But menopause will encompass the entire rest of your life, which for most women is 30 to 50% of your lifetime. But the time commitment necessary to get this education will amount to less than 1% of your time. I'd say that's a lot of bang for your buck. Oh, I forgot. This education is free. So, by merely watching all my free videos in order, you can make the rest of your life the best of your life. Not a bad trade-off if you ask me. My dream is for all women to get this education in their 20s and 30s. That way they'd have plenty of time to watch the videos in a leisurely way, and they'd be fully prepared when they encountered menopause. Even if you've already been dealing with menopause for a long time, even if you're dealing with it now, or if you're finished with perimenopause, it's never, ever too late to get this education and make a huge difference in your future. So that's why I cover everything in units. And this is the unit on cervical cancer. I don't even address cervical cancer in my book. That's the great thing about these videos. I can cover everything. So let me orient you to where we are on the topic of cervical cancer. In video number 342, you learned that cervical cancer begins in the transformation zone of your cervix, where the squamous skin cells of your cervix down here meet the columnar gland cells of your endometrium up there. And in video number 343, you learned that the cells progress through a parade of dysplasias before becoming cancerous. Then, in video 344, you discovered that the symptoms of cervical cancer are very commonly misconstrued by women, resulting in late diagnosis of the disease. And in video 345, you saw that such a situation is one that lends itself very well to a screening test in which it is possible to diagnose the disease before it becomes symptomatic. And the familiar pap smear is such a test. But then, in video 346, I taught you that after successfully employing the pap smear to decrease deaths from cervical cancer, we discovered the actual cause of cervical cancer, which is the human papillomavirus, or HPV. And because we now know the actual cause of the disease, it's time to talk about testing for HPV itself as a screening method. So this video is on screening with pap smears versus screening with HPV tests. You know, there's great value in knowing the cause of a cancer. It can really change everything about how we go about detecting, treating, and curing the disease. And hopefully it induces people to prevent the cancer altogether. It's truly phenomenal that so many lives were saved from cervical cancer before we even knew the cause. And pap smears are the very reason we've been able to save so many lives. But even though the pap smear represents the perfect screening test, it doesn't mean it's the only option for a screening test. You know, for some cancers, we have no screening test at all. But for cervical cancer, we have two. This reminds me of a television commercial that used to air when I was a kid. It was a commercial for Double Mint gum, chewing gum. And the jingle for the commercial was two mints in one. So for cervical cancer, we now have two screening tests instead of just one. Well, now that we we know that HPV causes cervical cancer, the question becomes, which is better at screening for cervical cancer? Looking at cervical cells under a microscope by doing a pap smear, or testing for the HPV virus? Well, first we need to designate what constitutes testing for HPV. Do you recall my telling you that your doctor performs a pap smear in just about 5 seconds during the course of your pelvic exam? A pap smear is as simple as your doctor swabbing the hole in your cervix with a wooden or plastic spatula or a brush. If we use this model, which is a model of the cervix along with the uterus and reproductive organs, it's like this. It's that simple. It takes that long. Well, guess what? The HPV test is just the same. The only difference is that we don't use a spatula. We use a special brush. We do like that. So the pap smear and the HPV test are identical in terms of the process of getting the sample from your cervix. And I've told you before that there are certain criteria a procedure must meet in order to be considered a good screening test. So let's look at the pap smear and the HPV test side by side to see which one makes the better screening test. But first, let's just review the criteria for a screening test in general. A screening test is a procedure that serves the purpose of detecting a disease in its early phase. In the case of cervical cancer, the goal of a screening test is to detect cellular changes in the pre-cancerous phase before they ever even become cancer. In order to be acceptable, a screening test must serve the public at large rather than the individual patient, be inexpensive, be simple and accessible, be useful when the cancer is early, asymptomatic, or precancerous, and be sensitive, meaning it must focus on the possibility of cancer rather than on the actual presence of cancer. This last item is called sensitivity. Sensitivity refers to the test's tendency to overdiagnose the presence of abnormal cells rather than to underdiagnose them. It has to do with overestimating the presence of disease rather than underestimating the presence of disease. A screening test that is sensitive is going to result in more false positive tests. In other words, sometimes it's going to lie. A false positive test means that you are told you need further evaluation to rule out the possibility of cancer. But that's going to happen in situations in which you don't have the cancer, so it's a lie. And with the need for further evaluation, you get nervous, anxious, and you probably turn to Dr. Google before you even know if you have a problem. But notice what's not on the list of criteria for a screening test. What's not on the list is specificity. Specificity refers to the test's ability to pinpoint a specific disease. It has to do with making sure it doesn't overestimate the presence of the disease. So a screening test that is specific is going to be more like a diagnostic test for one specific disease. Instead of a lie, it's verification. It has to do with making sure it doesn't overestimate the presence of that one specific disease. Well, a screening test is more of a catch-all net. Its job is to filter the abnormal from the normal without any real focus on just one particular disease. So in the case of cervical cancer, a test that is sensitive will capture all kinds of cellular abnormalities due to any cause. They may or may not be cervical cancer or precancer. They may or may not be caused by HPV. Other infections that cause the cells to look wonky may be designated as abnormal, even if they have nothing to do with cervical cancer or precancer. But a test that is specific is only going to capture the cellular abnormalities that are due to one one specific cause. It will only be cervical cancer or precancer, but it will only be cellular changes caused by one specific cause. Other infections that cause the cells to look wonky will not be designated as abnormal. So a sensitive test will catch a greater variety of abnormalities and sometimes lie, while a specific test will catch only one kind of abnormality and verify. I think the best way to compare two things, any two things, is with a chart. So let's make a chart to see which of these two screening tests is best. Here's a preview of our chart with rows for each of the parameters for a good screening test. Now we'll address each parameter to see how the Pap smear and the HPV test measure up on them. Starting with public use. Public use refers to the ability to perform the test on all patients. In other words, it is not limited to only certain women who have particular histories or symptoms. Well, in the case of a Pap smear, all it requires is that women get their pelvic exam, at which time the Pap can be done. And in the case of an HPV test, the very same thing is true. So they are both suitable for public use. That means that they both pass the screening test for use as a good screening test. So, what you have is two screening tests for public use instead of just one. So we're going to show this on our chart by giving each one a plus sign. Next is cost. Now, cost can encompass a few things. Obviously, it includes the monetary cost, but it can also include manual labor. You already know that both a Pap smear and an HPV test involve a pelvic exam, and you already know that they both involve collecting cells from your cervix. But then what? How do the processes for determining the results differ after that? Well, they don't. Both types of specimen go to the pathology lab where they are assessed. And the manual labor involved in assessing them consists of looking at the specimen under the microscope. The same kind of professional does both. And the time requirement is similar. In terms of US dollar figures, they both cost about the same. PAPs cost about $30 US and HPV tests cost between 20 and 30 US dollars. So there's not much of a difference in money or manpower. They are both relatively inexpensive, and that they both function well as screening tests with regard to that cost. So we have two screening tests at low cost instead of just one. So we'll give them both a plus sign. Alrighty, moving on to simplicity. Well, obviously, they're both pretty simple. And I know they're not fun, but fun and simple are two completely different things. As far as medical procedures go, both the Pap smear and the HPV test are simple for both you and the medical professionals that conduct them. So, here we have two simple screening tests instead of just one. So we'll give both a plus sign on our chart again. The next parameter is accessibility. Accessibility refers to availability. In other words, is it a test that is available only in major medical centers or only in developed nations? Or is it a test that can be performed in basic facilities and remote areas? For the most part, there is nothing sophisticated about either one in terms of necessary equipment. So they are both available in all but the most primitive circumstances. In other words, they are both readily accessible. So, two accessible screening tests instead of just one. So for accessibility, they both get a plus sign. Now we come to early detection. And you already know that they both detect cervical cancer at the early cancer stage or even at the pre-cancer stage. A PAP detects early pre-cancerous cellular changes, and the HPV test detects the presence of the virus that causes cervical cancer. The Pap smear detects cervical changes here at the dysplasia level. The HPV test detects cellular changes here at the cause level. That constitutes early detection for both of them. So we have two early detection screening tests instead of just one. So early detection is an easy plus for both. Alrighty, now for sensitivity. How well does a Pap smear screen for any cellular changes that could be cervical cancer or precancer, even if it's a lie and they aren't cervical cancer or precancer? Very well. That's why it was such a successful screening test story before we even knew the cause of cervical cancer. So it gets a plus for casting a wide net and catching anything that could be cervical cancer, even if it's not. So here's an analogy. Using this screen, notice that while it is a screen, the pore size of the screen is quite large. This means that it will filter out anything that is larger than the size of these openings in the screen. But it will let anything smaller than the openings in the screen pass through. Anything that passes through the screen can cause your Pap smear to be abnormal. So, here I have particles of many different sizes. Let's pretend that all these particles, except one, are entities that can result in an abnormal Pap smear. So, this one represents inflammation. Does it pass through? Oh yeah, it passes through. Inflammation. This one represents infection. Does it pass through? Oh yeah, it's passing through big time. You can hear it dropping, right? This one here represents trauma, going through like crazy. This one represents cervical irritation. Ooh, that's going through very heavily. This one represents HPV. Whoa, there it is. This one represents cervical cancer or precancer. That's definitely going through. And this one represents something entirely unrelated to cervical cancer or precancer. And as you see, it doesn't go through at all. So, of the 7 different particles representing the various things that can cause a Pap smear to be read as abnormal, only one of them is actually cervical cancer or precancer itself. And one of them was the actual cause of cervical cancer or precancer. But because this screen has such large pores, it let 6 of the 7 pass through. It is a filter through which many different things that can cause an abnormal Pap smear will pass. So it will detect cervical cancer and precancer, but that's not all it'll detect. And what about an HPV test? How well does it screen for any cellular changes that could be cervical cancer or precancer, even if it's a lie and they aren't cervical cancer or precancer? Very well. And that's because it detects the very cause of the things that become cervical cancer or precancer. So it gets a plus for casting a wide enough net and catching anything that could be cervical cancer. This is because it lets the very cause of it pass through. Once again, we have 2 tests that qualify as sensitive screening tests. Two sensitive tests instead of just one. So sensitivity gets a plus for both. And finally we have specificity. I added it even though it is not on the list of criteria for a good screening test. How well does a pap smear confine itself specifically to detecting and verifying just cervical cancer or precancer and ignoring all other things that can make cervical cells wonky? Not very well. Remember all those other things that were able to pass through this screen in addition to the actual cause? A pap smear can be abnormal because of inflammation, infection, trauma, irritation, in addition to cervical cancer or precancer. That's why it produces so many false positives. An abnormal pap just tells you to look more closely to find out what's causing the cells to be wonky. It's often a lie and cannot verify. So it gets a negative sign for specificity. What about the HPV test? How well does the HPV test confine itself specifically to detecting and verifying cervical cancer or precancer caused by HPV and ignoring other things that can make cervical cells wonky? Very well. It's more like this. So if we consider a screen with a smaller pore size, it is more selective or specific as to what it will allow to pass through it. So if we go back to our particles of varying size that represent all the things that can cause a pap smear to be abnormal, this one doesn't pass through. 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 Huh. Well, look at that. This one comes through beautifully. It's the only one that came through. And of course, our things that were huge on the other screen are definitely not going to pass through this one either. But we have one single item that passes through, and it's HPV. The only one that passes through the screen is the one that represents HPV itself, the true cause of cervical cancer or precancer. So you can think of specificity as a screen with a smaller pore size that only lets the real thing pass through it. This is in contrast to sensitivity, which is a screen with a larger pore size that lets the real thing as well as some false things pass through it. The HPV test serves one purpose and one purpose only. It is specific for HPV. It does not lie. All it does is verify. So we'll put a plus on the on the chart for that. We can't do my fun 222 this time. So now you see that the only real difference between using the pap smear as a screening test for cervical cancer and using the HPV test as a screening test for cervical cancer is specificity. In that regard, the HPV test is superior. But the question now becomes, does that mean HPV testing is better than pap smears? And that brings us to the dilemma of whether it's better to use just the pap smear, just the HPV test, or both for screening for cervical cancer and precancer. The reason I bring this up is because after the discovery that HPV caused cervical cancer, the ability to test for HPV began to be proposed as a replacement for the pap smear as a cervical cancer screening test. And when things like that happen, you end up getting confused. You hear about these controversies in the news, and you hear about certain societies changing their guidelines, and you never get the whole story. Before 2008, there was just one set of guidelines for cervical cancer screening. All women from age 21 on were to get an annual pap smear, and they got them every year for the rest of their lives. It was very simple. That's why you're so familiar with the pap smear. But that was before we knew what caused cervical cancer. Once we knew the cause, society started proposing increasing the interval between pap smears. Why? Because, as I taught you in the last video, it takes decades for HPV to change the cells into cervical cancer cells. So some societies proposed a pap smear every 2 years. Others proposed a pap every 3 years. Both proposals stipulated that the increased interval between paps depended on 3 consecutive normal paps first. So if you'd had 3 consecutive normal paps, you could start getting your pap smear every 2 or 3 years. So how does that affect the statistics on cervical cancer rates? Remember, all guidelines for all screening tests are always about the entire population. They are never about you. So any changes in the rate of cervical cancer are population-wide changes. So what happens if you extend the interval between pap smears from every year to every 3 years? Well, it means that there will be 3 to 5 additional cases of cervical cancer for every 100,000 women. This is double the risk with annual paps. That's not many, unless you're among the 3 to 5 who get it. Then, there were proposals to stop screening for cervical cancer altogether at age 65. Why? Because once doctors and scientists knew that HPV caused cervical cancer, they were able to determine the timeline of the disease. In video number 344 on the symptoms of cervical cancer, I showed you a timeline of cervical cancer. Remember this? And from this timeline, you can see the exposure to HPV virus at age 20 does not manifest as cervical cancer until about age 50. So the timeline for developing actual cancer is a long one. And if you consider the fact that all guidelines always take economics into account, the guideline makers for cervical cancer screening are saying, hey, why spend money testing for early changes in cervical cells that will take 30 years to become cancer in women who are likely to die before then? They always justify such proposals by saying that it's not cost effective to screen older women. So some guidelines recommend cessation of cervical cancer screening in low-risk women over age 65 who have had negative screens in the previous 10 years and no abnormal cervical cells in the previous 20 years. Then, in 2012, there were proposals for co-testing with both the PAP and the HPV test. But along with that proposal came the proposal for increasing the interval between screens. So by 2017, there were guidelines for women aged 30 to 65 recommending a pap smear alone every 3 years or a pap and HPV test every 5 years. The stated goal is always to decrease cost without increasing deaths from cervical cancer. And there is always something that the guideline makers call harm. Harm is anything that causes a screen-positive woman to undergo additional testing that turns out to be a false alarm. In other words, it's anything that results after the fact in the screening test results being a lie. Now, this is a bit ironic, don't you think? I mean, the whole purpose of a screening test is to cast a wide net and overdiagnose rather than underdiagnose. It has to do that in order to qualify as a screening test. But then, when the screening test does just that, they call it harm. Of course, a false alarm does cause a lot of anxiety for you. But would you rather have anxiety over a false alarm or anxiety over actual cancer? You can't have it both ways. I chuckle when I read medical studies and medical journals sometimes because the minutia overtakes the big picture to the point of ridiculous at times. And notice that the stated goal is always to decrease the number of deaths. It is not to decrease the number of women who get cervical cancer or the number of women who have to go through treatment for it. You would probably rather focus on avoiding the cancer altogether, but most guidelines don't do that. And there's another irony. Despite all the focus of these societies on avoiding the harm of overdiagnosis and additional testing, they fail to focus on the harm of getting and treating the cancer itself. Would you rather endure the harm of a screening test that lies and ends up being a false alarm? Or would you rather endure the harm of getting the actual cancer because you postponed the screening test and therefore you got the actual cancer and had to treat it? The most recent guidelines in the year 2020 are for an HPV test starting at age 25 instead of age 21. And then every 5 years thereafter. And the reasoning for starting at age 25 instead of age 21 is that women younger than age 25 have too much exposure to HPV. The 2020 guidelines go on to recommend that if the HPV test is not available, these women should get a pap smear every 3 years. So notice that these new recommendations adjust the interval for testing depending on which screening test you use. For the HPV test, it's every 5 years. For the pap smear, it's every 3 years. And that's because the HPV test makes the diagnosis way up here, whereas the pap smear makes the diagnosis here. The new guidelines also comment on the effect of co-testing using both the pap smear and the HPV test. Two screens in one. With gum, apparently it's good to have two things in one. But with these proposals for both screening tests in one, they claim that co-testing results in more harm because it leads to more follow-up evaluations or false alarms. Maybe the problem is lengthening the interval, regardless of which screening test you get. Maybe we should just utilize either test starting at age 21 and do it every year for the rest of our lives. Then we wouldn't reverse the success we've seen with the pap smear. The way in which the pap smear and the HPV results are reported differ just a bit too. They both indicate the same things. They just use different terminology for describing the findings. Here's a chart of the possible results for the two screening tests. For pap smears, which is in the pink row, pathologists designate one of 6 findings. Normal means, well, normal. The cells look just fine. Atypical squamous cells of undetermined significance, or ASCUS, means that the cells look odd or inflamed, but it's difficult to give them a diagnostic description or label. Next, you see 3 cells with the acronym CIN. CIN is the acronym for cervical intraepithelial neoplasia. Cervical means it pertains to your cervix. Intraepithelial means that the abnormal cells are confined to the squamous skin cells that exist on the part of your cervix that is exposed to your vagina. Neoplasia is actually a misnomer because there is no invasive cancer present at all. But I want to linger here for just a bit. Recall that I've referred to the phenomenon of breaking the barrier for both of the cancers we've discussed thus far. I've told you that it represents that point in time when a disease process transitions from one of non-cancer to cancer. And sometimes the transition is so difficult to pinpoint that the term used to describe it is either vague or somewhat contradictory. The word intraepithelial literally means within the epithelial cells. So it has to do only with the individual cell. And the word neoplasia means cancer. But there's a contradiction here simply because, by definition, cancer is cancer not because of neoplasia within individual cells. Cancer is cancer because of the invasion of those cells into areas where they don't belong. So there are really 2 different times in which a disease breaks the barrier. One is at the level of the individual cell. The other is at the level of the surrounding anatomy. If all you have is some individual cells that contain neoplasia, you do not have cancer. You have cells that may or may not go on to behave like cancer in the future, but you do not have cancer. So the term cervical intraepithelial neoplasia is somewhat of an oxymoron. There is neoplasia in some of the epithelial cells, but they have done nothing in the way of behaving like cancer and invaded the surrounding anatomy. And you'll discover in later videos that cervical intraepithelial neoplasia is not treated as if it's a cancer. It's still treated as a pre-cancer. Okay, so now going back to our reporting system for pap smears, here's the chart again. Mild dysplasia is designated as cervical intraepithelial neoplasia 1, or CIN1. Moderate dysplasia is designated as cervical intraepithelial neoplasia 2, or CIN2. Severe dysplasia is designated as cervical intraepithelial neoplasia 3, or CIN3. And frank cervical cancer is designated as squamous cell carcinoma, or SCC. HPV testing results are in the periwinkle colored row. For HPV, pathologists designate 1 of only 5 findings. Negative means no HPV is present. Atypical squamous cells of undetermined significance, or ASCUS, means that the cells look odd or inflamed, but it's difficult to give them a diagnostic description or label. The next cell shows the acronym LSIL. LSIL is the acronym for low-grade squamous intraepithelial lesion. Low-grade means it's just mild dysplasia. Squamous intraepithelial means that the abnormal cells are confined to the squamous skin cells that exist on the part of your cervix that is exposed to your vagina. And notice that with HPV, the terminology does not use the word neoplasia. Instead, it uses L for lesion, which is much more correct and accurate. Next to the cell bearing LSIL, you see one with the acronym HSIL. HSIL is the acronym for high-grade squamous intraepithelial lesion. High grade means it's moderate or severe dysplasia, and squamous intraepithelial means that the abnormal cells are confined to the squamous skin cells that exist on the part of your cervix that is exposed to your vagina, and L is for lesion. And finally, SCC is for squamous cell carcinoma. The biggest difference between the two is that the PAP results separate moderate and severe dysplasia into two separate categories, whereas HPV results group them together as one category. So, what I want you to understand is that when you see guidelines changing, there are always trade-offs. Either the cost of screening has gotten too high, or the probability of the disease causing death past a certain age is low. Or the likelihood of the screening test inducing other tests is causing anxiety. But all of those things are assessed on a population-wide level. I'm a big believer in peace of mind, and I think that no matter what the guidelines recommend, you should do what gives you peace of mind. Your doctor probably just follows the guidelines. Your insurance will probably only pay for what's indicated by the guidelines. But you should do whatever you need to do to give yourself peace of mind. I don't think there's a right way and a wrong way, and I do not think all women should be doing the same thing. We are all different in terms of our comfort zones and need for reassurance. So do whatever falls within your comfort zone and assures you that all is well. That's the whole point of a screening test. And when you hear a news report on a change in guidelines, don't freak out. Don't get mad. Just get as many facts about the reasons for the change as you can and do whatever you prefer. Do not get your information from the media. Either do all the extensive research of the actual medical literature that led to the change, or set up a consultation with me and let me present the whole story to you. You are not a prisoner who has to follow the guidelines. You can do what's right for you, even if you have to pay for it. Okie dokie. Your summary for today is that both the Pap smear and HPV tests are excellent screening tests for cervical cancer and precancer. The Pap casts a wider net and flags abnormalities other than just cervical cancer or precancer, while the HPV test is specific for the HPV virus that causes cervical cancer and precancer. The changing guidelines are an effort to increase the interval between screenings and decrease the duration of screening in order to save money while avoiding an increase in deaths. Regardless of changes in the guidelines, always be true to yourself and do what gives you peace of mind. Okay, that's it for today. I hope this helps you understand screening and guidelines in general, and those for cervical cancer in particular. If you'd like a copy of either or both charts, you can find them via the link in the description box, or you can go to menopausetailor.me where you'll find all my charts. Next week, we'll move on to the diagnosis of cervical cancer. Subscribe here to my channel and my newsletter before you go, and between now and next week, please go to menopausetailor.me. Read some of the fun articles there, shop in my store for educational resources, schedule a consultation, and then follow me on Facebook, Twitter, Pinterest, and Instagram. Bye for now!